Good afternoon. We'll go ahead and get started. We'll have a news release up here for you in a few minutes to kind of capture the updates of the day, but we promised or committed that we would come to you when we had some news and try to update you on a regular basis as to how we're preparing for and responding to the coronavirus. So we were at that point at the end of the week where we thought it might be a good time again to do another update. So Dr. Mark Newman is the Executive Vice President for Health Affairs at UK. He's here. He can handle any kind of hospital policy questions and how the overall healthcare enterprise is handling this issue. But I thought we'd go right into some of our clinical people and university folks who are dealing with specific issues. First is going to be Dr. Derek Forrester, who's the Medical Director of our Division of Infectious Diseases, and then Kim Blanton, who's our Nursing Operations Administrator for that area, and Sue Roberts then will kind of wrap up, who's the Associate Provost for Internationalization at UK. And we'll get right to it with Dr. Forrester.
Thank you, Jay. So I did want to start with just a positive. So our patient that we had confirmed last Friday has fully recovered and was discharged today. So we're excited about that. Excited for recovery there, and just really proud of the staff and the people that took care of them, and so we're really excited about that. I did want to kind of give a few updates here as far as testing and just protocols in general. So as far as testing goes, we continue to follow the guidance that's out there as best as possible regarding testing. We're working with our Kentucky Department of Public Health, Division of Laboratory Services, for testing primarily patients that might be admitted and may have some indication for testing, and then mainly working as well with our commercial laboratory reference labs like LabCorp and FireCorp and a few others for testing as well. So we continue to do that. We are not testing asymptomatic patients, and I want to make that clear. There is not an indication. If there are no symptoms, there's no indication or no reason to test, and that testing result can be misleading. So, so I just want to make that clear. We're not testing patients without symptoms. As it relates to infection control guidance, we continue to work with our health department folks and follow the rapidly changing CDC guidance as new information comes out to provide care and protect our healthcare workers for anybody who may be positive, or for anybody that we're investigating or sending testing out as well. Also wanted to just note one thing. Our laboratory folks, blood bank folks, tell us that there are, unfortunately, some of this stuff is leading to decreased blood donations. And so I want to make a point for all the folks that are out there who otherwise maybe would have been giving blood during this time. This is something that's still needed for Kentuckians and for our fellow people, that you can still give blood, that there's practices in place to keep you safe while you're doing that. So I know we're certainly in a position public health-wise where we're trying to limit large gatherings and contact, but I certainly do want to encourage folks that have the ability to do so to continue to do so. I think with that, I'll stop and see if anybody has any questions, and then throw it over to the other folks here.
I guess just about the blood donation, are there even any increased risk at all in going to give blood?
No, there wouldn't be, just for going to give blood. No, it'd be perfectly safe to do that.
How many beds and ventilators do UK have?
I don't have a total number. Maybe Dr. Newman or Kim can give you that information.
About the ventilators?
Yeah, you can do that. So, thank you. I mean, we have, obviously we have 945 beds overall. 152 of our beds are isolation negative pressure rooms to be able to, so we have, again, as we talked about before, we have more than enough capacity to be able to meet the needs. But that's how many, isolation negative pressure beds that we have in-house.
Does that include the ventilators as well?
Ventilators is another question.
So our supply of ventilators is on 140. For instance, today we have 55 that aren't in use. So we just ordered 25 more this morning. Mm-hmm.
Talk to me about how prepared UK is for an influx of patients if that were to be the case.
Again, we continue, we literally daily go over our disaster preparedness plans and talk about what we would do if there was a major influx. Right now, again, we don't have any patients who have tested positive in-house. So we are continuing to work and take care of patients as we would on a daily basis. And so I think, but if that numbers were to start to rise, then we have a disaster preparedness that starts to focus more on those patients and how we would manage those and potentially not do elective cases or other things as we move into more of a disaster preparedness. So again, that would kick in as it's needed.
Have you seen a spike in people reporting the emergency room, just more worried that they may have these symptoms? They woke up with a fever, but it's not really consistent with the CDC criteria.
I think our numbers are fairly similar, maybe slightly up. And I think we have a nice triage approach to those patients. So as they come in, we identify for all patients. We look and identify, do they have a fever? Do they have risk? What are the issues along those lines? Typically, if they come in and they're just worried, we're going to reassure them, again, try to isolate them in case. But again, they'll probably be, be going back home to recover and do better at home unless there's some other reason that they would be in the hospital.
Could you give us a walkthrough? A person has the virus. Could you walk us through, in generally speaking, how they get treated? Because there's no cure for it, right?
Yeah, so I want to emphasize the majority of people that get COVID-19 will have mild disease and will fully recover. I mean, over 80%, at least in the studies, never even have significant disease. So those that are admitted, the treatment right now is symptomatic. So you're assessing for other things, any other thing you can treat potentially, and then you're managing through their course while their immune system kind of takes over and helps them recover. So that's, right now it's symptomatic and supportive care management. But again, the majority of folks are going to have mild disease if they have symptoms at all, and so they'll be able to manage at home.
So my question is, what specifically do you do? Do you hook them up immediately to IV? You immediately give them blood? You immediately give them antibiotics? I don't know. What do you do to the patient?
So we treat them as we would treat any patient that's coming in, and it's based on clinical assessment. So the fact that they may or may not have COVID-19 doesn't change how we assess a patient and what we do in the initial response. So if it's clinically assessed and labs come back and they need fluids, certainly they'll get fluids. If they need respiratory support, certainly they'll get respiratory support. But there's nothing like just based on somebody coming in with symptoms, there's nothing different on the front end that's done. It's everything's managed right now as we would manage any patient.
Just to clarify, the patient who has been released is recovering. That was the first confirmed case in Kentucky from last Friday.
That's correct.
Right? Okay.
Yep.
And do you have any other patients in isolation here?
We don't have any other confirmed patients. We have tested, some other patients as well, and they've all come back negative.
And this may be an administration question, but is it true that the hospital is running low on supplies in terms of protective gear? We've heard from nurses who've gotten notices from the hospital advising them to use protective gear sparingly.
Yeah, you guys might be able to talk about that.
Kim, you might go ahead and talk about the other topics you've got.
Oh, okay. So from a supply issue, we sent those emails out just to be sure that everybody knew that we need to allocate. What we were seeing was that people were stockpiling them and taking them home. And I'm not meaning just our staff. We had people just taking them out of our respiratory etiquette boxes, handfuls of masks and things. And so we need those for our employees to keep them safe while they care for patients. And for our visitors and patients that come in that require a mask for other things other than just COVID-19. So that's why those emails went out.
You saw patients grabbing and stockpiling, or just people in the hospital who were not staff members?
We have seen all of the above. Yes.
You said that you don't have any COVID-19 patients confirmed right now in the hospital, and this might be a question for one of you too. Isolation beds, how many people are actively being monitored in an isolation bed right now?
For just COVID-19 symptoms? At this point, we're allowing people, the physicians, to order, and so we don't keep up with the number of how many they're ordering every day until we get a call back from the state and the commercial lab. So I can tell you, several of these people were tested and went home, like from our emergency departments and things. So they're not all in the hospital. Okay?
What's the checklist?
Well, let me just, I mean, we can have patients in isolation for a number of other reasons, and I think that's the thing I would say. I don't know that we have anybody for COVID-19 right now, but we have patients in isolation all the time for different reasons and different things as a part of how we keep people safe and how we keep our staff safe as a part of what we do. So again, from that standpoint, we would have people in isolation every day. I think the number for COVID-19 is either 0 or pretty small right now because most of them have all tested negative.
And just to follow up on that, as Dr. Newman said, on average, just for normal isolation in a normal day here, we have over 150 people in isolation that has nothing to do with this COVID-19.
How taxing has this been on the staff? I've spoken with nurses who have complained about not getting adequate lunch breaks or even being able to go to the bathroom for several hours at a time. What are you doing to ensure that they're compensated for more time they work and also make sure they actually get breathing time?
Well, several things. First off, we compensate people for all the work that they do, and we recognize, and a note will go out from me, to all the staff this afternoon, appreciating again the commitment, the tenacity, and all that. Because realistically, when you think about staff, when you think about healthcare workers, they are at increased risk, and that puts themselves and their family in some level of increased risk. We do everything we can to reduce that risk and reduce their exposure, and that's the key aspects of us managing on a day-to-day basis to reduce that. So I think from that standpoint, we do that. I mean, these are, again, challenging, as we will have issues as the schools are not going to be in with people with child care and other things that we will try to work and help with those type of things, and we're working on those things now. And that's the issue, I think, is you've got a great group. I think that if you go around area to area, the morale is really good and the commitment is really strong because they know that they're doing something that's important for us all.
Can you expand on the child care aspect? You said you started having internal discussions about that. What are those options look like?
Well, we're just looking at how we work together with the university and the partners to look at what are the options to expand that as you think about individuals that work for us that have, again, children in school in particular that are, with the schools out, that's going to be an increasing challenge for us. So we will work with and for our employees to give them the best options so that they, their commitment, is recognized by how we support them.
My mother was a big believer in vitamin C, and her son is too. So is taking something like vitamin C off your pump up your immunity and something like this?
So there has been a lot of interest in vitamin C in the medical community for a while, and they've looked at it even for things like sepsis and that kind of stuff that hasn't been really impactful from the acute care standpoint. But I think just general health is good. I have no issue for people taking multivitamins or vitamin C. Do I think there's any major benefit in this setting? No, I don't. But I think it's good to be healthy. I think it's good to stay active. Obviously a lot of things are being canceled right now, and a lot of people are staying home. I do want to stress the importance, though, of staying active and being healthy in general. I think that will help anybody who may come down with the flu or any respiratory illness or COVID-19 have a really good recovery and outcome. So I would just suggest everybody's do what they can to stay healthy during this time. Think about each other. If you have somebody that may be at higher risk, like an elderly person or a neighbor that has issues, this is the time for, I think, community to come together and just look after everybody else while we're while we're not thinking about basketball, I guess, as we move forward.
I got a quick question about the over 60 crowd.
Mm-hmm.
So all this is a little bit, it moves an awful lot, right, this whole discussion. But
Yeah.
A healthy 60-year-old should not go into a big gathering. I guess that's my question.
Well, so the question was, should a healthy 60-year-old be in a big gathering or large event? I guess my first thought was, I don't know if you can find a big gathering anymore in the area. But my second thought is, it is up to individual risk. And so that literature and those recommendations come from a broad populational assessment. And of course, not every 60-year-old is the same. And so that's something that I think everybody has to assess individually as far as what their overall health is and what other maybe additional things they may have going on during that time. So.
You mentioned that only patients who are showing symptoms are being tested. What is that checklist of symptoms that must be met before a patient can be tested?
Well, now with the reference laboratories online, technically anybody could be tested by any provider in the state or anywhere else for that matter. Now, again, it doesn't really help much or give much information to somebody who doesn't have symptoms, because there are false positives, and a negative test doesn't mean they couldn't develop symptoms or test positive later on. So it is important to recognize people with symptoms, and so primarily that's fever and cough, and that's what we tell them folks. Fever and cough, and from our standpoint, we've been assessing them first for more common things like influenza, which is still circulating very high right now. And then if they test negative for those things, potentially they could be considered for testing for COVID-19.
Did you say that you have the capacity to test here? Is that what you said on the front end of that?
We don't have the capacity to test in-house right now. Yeah, we're testing through, sending specimens through the state lab and then some of the commercial laboratories.
Can you put all this into context for us? How does this response compare to, say, something like H1N1? And also, how do you characterize the federal government's response?
Well, trying to think of this through the context of the science of those two things. You know, I think this being so new and different than influenza, which H1N1 was, and that came on very rapidly and suddenly, and we were able to generate vaccines and stuff for that. I think those things, and we had medications for influenza, I think those things make that issue different in 2009 when H1N1 came out. Now it's a setting of, you know, doing interventions from a public health standpoint that the CDC calls non-pharmaceutical interventions. So we don't have vaccines, we don't have medications per se. And so those interventions are really about trying to just limit the spread. And that's where we talk about all the social distancing and the event cancellations and those type of things.
It seems like over time people keep invoking 1918.
Oh, yeah.
Is that fair to draw a comparison?
No, I don't know. 1918 is the gold standard for pandemics. I mean, every modeling study that you ever see references back to the flu of 1918. And so is it fair? I don't know, but that's, you know, when you're the gold standard, it's going to get used and get referenced.
As far as the testing, have there been any false positives, false negatives so far that you may know of?
No false positives that we know of. And of course, from a false negative standpoint, I'm not 100% sure of the sensitivity of the test, but from a false negative standpoint, not that we're aware of, no.
What's the average length of stay for a COVID-19 patient?
Well, we've had one patient, and they came tested on Friday and went home today. So I guess I'd say the N of 1 would be 7. Now that was a much different scenario. I mean, I don't know what that will be in the U.S. Certainly in other parts of the world, it's been somewhere around 5 to 7 days.
Does University of Kentucky expect an influx? I know that you're not able to say for certain, like conjecturing, because you have to prepare.
Yeah.
Do you all expect an influx of COVID-19 positive patients? I know that people are visiting hospitals now, maybe a little bit prematurely with symptoms that scare them, but they don't actually test positive.
Yeah.
Do you expect, in your expertise, that you all will be, maybe not flooded, but you expect to be sort of pushed to the brink?
I definitely expect more cases. I think that's pretty clear. I guess we'll have to see. Obviously, we're making those plans and stuff that we're talking about every day about what those things look like and trying to stay on top of the numbers and what's going on and what type of visits are we getting. So I don't know. I don't anticipate that, and I think a lot of the work that the public health group and the governor has done as far as getting these events to stop, I think are really helpful, and I think will help what they call flatten the curve on this thing and help us not get, not just us, but the healthcare system, in Kentucky and really in the U.S., keep it supported.
We've heard about hospitals sort of developing kind of ad hoc rooms where if they have COVID-19 patients come, that's where they would keep them. Isolation beds are probably something similar. Is there a designated area in the hospital that you all are only using for COVID-19 patients?
We have a designated area that we would be using to keep them together or to cohort them. But right now, again, we've only had the one patient, so.
If a patient who tests positive for COVID-19 is not sick enough to be hospitalized, but say they self-isolate, we've had some questions from viewers just confused about what that entails. Can you give some guidance on how they should self-isolate? Obviously, there are people who live in houses with 5 or 6 other people there?
Yeah, well, the health department would be involved in that, of course, right now. So the guidance that they're giving right now is to stay at home and have a place in the house that they can be separated from the other people in their house, especially those that may be at high risk or have, medical health issues that would put them at risk for having a more severe disease. And as far as how long they would stay there, I don't know the answer to that. That's kind of up to employee health right now. The health department.
If I could, let me shift gears for just a second. We've had some questions this week around another topic, some close and quick coordination between the university and the UK HealthCare this week to work to bring home about 70 students who have been in Europe in level 3 designated countries by the CDC. So I'm going to have Sue Roberts come up, who's our Associate Provost for Internationalization, to talk a little bit about that process, and then Kim Blanton will talk about how we were working with them to ensure their health care.
Yeah, so we had about 70 students in Europe who are participating in education abroad programs when the travel ban was announced on Wednesday evening. And so since then, University of Kentucky International Center staff have been working around the clock to get those students home. So this has involved informing the students of the new situation, perhaps coordinating with their parents and travel agencies and the host universities where they were studying, and getting their travel arrangements home. So as of right now, some of those students have returned home already. They're back in the United States. Others are on their way, and others will be arriving very soon in the next couple of days. When those students return to the United States, they're returning to their permanent addresses, to their family homes. So in most cases, they're all over the United States: Chicago, Florida, New York, California, all over. Some are here in Kentucky, and in a few cases, they're returning to campus, but that's a very small number. In every case, they are working with our University of Healthcare professionals, and particularly with Kimberly Blanton, on a protocol. So I don't know if you want to speak about that, Kim.
So my office and I are calling all of these students and touching base with them. We're giving them some directions on how to self-isolate for 14 days. And then they get a link, and they either call me directly or they use that link to report their temperature and any symptoms every day. We don't hear from them, then we call them. And so we've been doing this. Actually, we started this back in January with the International Students Office when we brought home our Chinese American students. And it went very well, and we've continued it through this 70-some students. And so they've all been very excited to get a call from one of us, and even their parents call me, and we can answer their questions. So just to support them through this.
Is the university funding these flights back home to the U.S.?
Yes, the policy is if the University of Kentucky instructs a student to come home, then we help them with the flights. In some cases, it's just a cancellation, not a cancellation, a change of a ticket fee to an airline. In other cases, we've had to buy tickets to get them home. But we are helping them financially, yeah.
How many different countries are they coming from?
We had the majority of our students in Europe were studying in Spain. The students from Italy had already come home when that country was designated by the CDC a level 3 a few weeks ago. But we also had some students in France and in Germany, and a few others around the continent.
Is there a date that you expect all of them to be here?
I think that they'll all be back by Sunday or Monday. And then really, there's just a few stragglers coming in on Sunday and Monday.
You said some are back. Can you give us a hard number on how many?
When I checked this morning, I think 3 were already home, and the vast majority are in the air or in transit somewhere. So they could be in a taxi getting to the airport, or they're in the airport, or they're in the air, or they're coming through customs.
Can you tell us about some of the challenges of making a last-minute international flight?
Yeah, it's been very difficult. Remember, these students were not expecting this news. Nobody was. We weren't, and the airlines were not. Their host universities were not. In some cases, they were living with host families. Nobody was expecting this. So it's been a major disruption, and in a way, a little bit heartbreaking, because these students have been having the time of their lives. They've been discovering things about themselves they didn't know before. They've been thoroughly enjoying being immersed in another culture. They've been enjoying their courses. They have made friends. And it was a really an unwelcome development for many of those students. Of course, they understand why this is happening, but I think it took a while for that to sink in. And then, of course, the travel difficulties were severe on Wednesday night. A lot of people were scrambling to get on planes across the Atlantic. And I think that made it very difficult to get flights for some of these students. But we did manage to do that, and they're all ticketed and on their way home in one form or another.
I understand why they would want to come home, but I also understand Europe has cases, United States has cases.
Yeah.
So there's a chance you could get it in Europe and a chance you can get it when you come back here. So what would be the difference? You understand my question?
Yes, I do. So we look very carefully at the cases in different countries around the world and the rate of spread of the disease. Along with our healthcare colleagues here, we rely on the CDC and on Johns Hopkins University's data on the facts to make decisions about when to return students or to ask them to return. You're right, though. It's a different situation than, let's say, if there was a tsunami in a country and you know you're taking students from an area which is under strain and removing them back to a safe place far away from that danger. This is a different situation. So this is unprecedented for managing this situation for universities and for study abroad professionals.
And I might mention too, we had two triggers that sort of occurred this week. Mm-hmm. One is most of Europe is now designated level 3 by CDC, one. And then two, President Trump made the proclamation Wednesday night with respect to a suspension of travel. Now, while that did not apply or does not apply to U.S. citizens, it is an indication of how quickly this situation is changing on the ground. I mean, things are in 24 hours, 48 hours, major policy developments are changing. So Dr. Capelouto, President Capelouto, in consultation with Dr. Roberts, thought the appropriate and prudent step would be to go ahead and bring those students home now. But those two sort of policy triggers informed the decision this week.
A lot of cancellations going on. I mean, our study abroad programs for, I guess, the spring, perhaps the fall, are they canceled? I mean, the summer or the fall?
We haven't got to the fall yet. The summer programs are under review. And we will be making a decision before next Friday, before March 20th, and communicating that decision to all students who are planning on studying abroad this summer.
I have a question. The president is apparently set to declare a national emergency in the next half hour or so. Obviously, that would allow states to access tens of millions of dollars of funds in the disaster relief fund. It sounds like you guys are prepared, but how would the state be able to help hospitals, I guess, build up capacity, ones that are struggling, don't have enough beds with that money?
I think obviously we want to work both ourselves and with our hospitals and health departments around the state to look at what those new funds are and how we can bring those in to best provide the safe care we are, but be able to expand that. And so I think that's what we would look at. I think as it becomes available, it may be easier for us to do some additional testing and other things that may be more difficult now. So those are some of the things we would look at, what those options are. But I think as we see that, that's what we'll, like I said, it is just as Sue said, it is a very fluid process from day to day about what the options are and the number of patients. And we want to be able to respond, be prepared, but respond and see where we are right now.
Last year, visitors were restricted when flu was kind of big going on. I mean, do you anticipate kind of closing off visitors?
Visitors are restricted right now, and it's essentially the same, our flu type of protocol. Right now, we just need to make sure we need to enforce that flu protocol is really what we're intending to do right now. We don't have anything else planned. But that's where we are from a restriction of visitor standpoint. Again, it's all about protecting our patients, and our people as they go about the work that they do. And that's the whole reason that we would restrict.
The patient who is discharged, back to them, just one question. I know that you all weren't able to confirm the age or the gender. Are you able to now that they've been discharged? We know that they are a Harrison County resident.
I think from our standpoint, we have kind of stayed in the process that it's patient information, and so we've stayed away from trying to do any of that. And I think that's where we'll stay as a policy.
Are there any other other questions, particularly for our clinicians? I promised them they could go back to the clinic today, or Kim Bland's going to beat me up. So they won't be able to do one-on-ones after this today. I apologize about that. But do you have any other questions for them right now? Okay. Thank you all very much.